Good afternoon, everyone, and welcome to Research Grand Rounds. So we have a sparse crowd here because we thought this was going to be virtual, but as I'm sure you, Dr. Callen needs no introduction, but I'm going to do one anyway because he's such a wonderful leader here and has developed such an amazing program for dermatology. So he is the Lafayette G. Owen Endowed Chair and Professor of Medicine and Dermatology, and he's chief of our division, excuse me, our division of dermatology. And he has actually been here at U of L, I believe, since 1977. Is that right?
Right.
Okay. And he is a almost cardiologist. I was loved hearing about that story that switched over into dermatology and has been a leader in that area ever since. He has an amazing number of honors and awards that he has accumulated over the decades, and his CV is incredibly long. And the funny part about it is it's incredibly long and thick and double-sided because of the massive number of publications and the everything that he's done in teaching and training a robust next generation of dermatologists. And he's going to describe for us today dermatology enterprise. Thank you so much, Dr. Callen.
Okay, let's see. So we have only 3 people in the room here, and there's some others online. I can't see them, can I? I mean,
So actually,
Double blinded.
yeah.
Actually, I'm interested as well, so I'll log in and tell you how many
You can
people.
tell me. Anyway, feel free to interrupt me because let's see. This is going to be probably totally different than anything that anybody has done previously with this conference, because I suspect that people come in and they talk about what they're actually doing in the research area, in epidemiology or in their basic research areas that they're doing laboratory research in. And I don't do laboratory research. I kind of said that when I was invited to give this, but Kim wanted to hear what's going on in dermatology research anyway, and said, but anyway, it's going to be totally different. And so I'm going to tell you about my career and tell you some stories as we go through it. It'll sort of fill in some of what Kim alluded to earlier there about why I'm not a cardiologist instead of being a dermatologist. But feel free to interrupt me because, and I don't know if I'm gonna, I don't know. I can actually tell stories that will fill the hour without going through. I had a mentor actually. We had set up something here in Louisville, and one of the guys who was one of my mentors came to give a talk, and he used one slide. And there was another guy who came to give a talk at the same session, and he used hundreds of slides.
Yeah.
And so people, can tell stories, and that's what I'm going to do today, is to sort of tell stories. So we're a clinically driven division. We have 5 people who are full-time faculty members, or at least 80% or more faculty members, and we have a number of volunteer faculty members, actually a fairly large volunteer faculty. We have a dermatology residency program, have 6 dermatology residents. And then we have a fellowship program in dermatologic surgery. And so we have 2 volunteer faculty in dermatologic surgery who are listed down there below that title, who aren't full-time faculty members, but who, because of that, still perform some clinically related research. And so we're going to talk I'm going to talk mainly about what I've done and then talk a little bit at the end about, and it's involved a lot of these people that are on here, about what's going on currently. Okay, so as I've said, I'm a clinician. I'm an educator, and I have been involved in educational efforts ever since I was and I was in training. I mean, I think actually when I was in medical school, I got involved in education. And I participated in clinical research, what I define as clinical research. Clinical research can be defined in a number of ways. You can have a basic scientist who is doing research that is related to clinical activities, and that's clinical research as well. I'm not talking about research necessarily that involves laboratory work, but many times I've participated in research in collaboration with others that have involved laboratory work as well. Let's see, early on in the time that I was here in Louisville, I performed some pharmaceutical trials. I found that to be really boring. And I didn't want to pursue that. I have a lot of friends in dermatology across the country who have pursued that. They've become trialists essentially, and that just wasn't my thing to do. Anyway, I've collaborated with lots of people. I'm going to tell you stories about them, and that's resulted in a lot of publications, lots of case reports. The other thing is in our residency, much as I think most of the residency review committees kind of mandate that the residents do some kind of academic thing that is beyond just seeing patients, and it involves either presenting or writing. And because of that, and the other thing is dermatology is really hard to get a position in. And because of that, we have students who come to us who are what I call derm wannabes, who basically want something, and they want to do some quote research, which in the instances when they come as senior students and they have about 2 months, means that they're going to write a case report. And so that's resulted in hundreds of case reports. I mean, I've become a case report king. And others in our division have become case report queens, and if they're of the opposite gender. Anyway, I'm going to describe and update you on some of give you a lot of sort of stories behind this. So why did I get involved in this to begin with? Well, my father was a cardiologist, and he practiced in Chicago. But one of the things that was one of his what he laid upon me when I was thinking about, should I go to medical school or whatever. One of his proudest moments, he said, was when he had a publication. And that was one of his initial publications. He went for a long period of time where he had no publications because he was basically in practice. And then he had some publications because I involved him in some, had some contacts at the medical clinics in North America, and he edited an issue of that, and he was doing some research at the end of his life. After he retired from clinical practice, he went to work at Miami Heart Institute on a volunteer basis and did some studies that involved, I think he was trying to poison dogs with adriamycin, which was certainly possible, but looking at the cardiomyopathy that the chemotherapeutic agent caused. When I went to medical school, I thought I was going to be an internist, which I am, and I had thought that I was probably going to be a cardiologist, which I'm not. And as a freshman student, I applied to do a research project, and I hooked up with a guy named Sunil Das, who was a cardiologist at Michigan at the time. And he had a lab where he was studying cardiomyopathies. And he was working with somebody named Jim Cassidy, who was actually a rheumatologist. And they were looking at immunoglobulins in the patients who had congestive cardiomyopathy, not hypertrophic cardiomyopathy. Now, I eventually, in my 4th year of medical school, I went to England to study with a guy named Goodwin, and he was working with somebody named Oakley. They were involved with hypertrophic cardiomyopathy, but even there I was working more on the side of congestive cardiomyopathy. Anyway, as a medical student, my work that I did in the laboratory, because it was in that case it was sort of a basic laboratory, and ended up in a publication in Circulation, as you see there, and that was that's probably my first publication, maybe. I think first in an official journal or something like that. So even I published in the cardiology literature a long time ago. So I trained in internal medicine, and then I had a fellowship lined up, but I became enamored by dermatology in the July of my second year of internal medicine, and I kind of switched over. But at the time that I switched, I also, in my second year of my fellowship, of my internal medicine residency, I was assigned a month in rheumatology, and I became enamored with the multi-system diseases that they see in rheumatology, and that's how I became interested in the interface between the skin and the joints, more so than the skin. And I'm what I would call a skin internist. That'll be on the next slide or so. But I was during my residency, when I was a first-year medicine resident, I had an intern who was under me named Schwartz, Richard Schwartz, and he eventually became a hematologist. And then our attending was a guy named Joe Silva. Joe Silva was eventually, he was in infectious disease. He was a junior faculty member at the time. And he eventually became chief of infectious disease somewhere else, not at Michigan, and eventually became dean of the School of Medicine at the University of California in Davis. So he was, and he tried to recruit me a couple of times to come out there, which I didn't do, but but I was working with him at that time. Anyway, I noticed I was sitting and taking a history and going over something that Dr. Schwartz had a patient that he had seen, and I was sitting at the bedside, and the patient said, the patient had Hodgkin's disease and was in the hospital to get treated. In those days, CHOP was the major treatment for Hodgkin's. And I'm sitting there and I'm talking to her, and I'm saying, and she says to me, we have a club in our hometown. And it was a really small town in sort of the center of Michigan. I should have a map and point out where it is. And this is going to drive you crazy, Kim, because what we would do anyway. She said to me, we have a club. We have a whole bunch of people who have had lymphomas, Hodgkin's primarily, but other with B-cell lymphomas and stuff like that. And it was a really small community. I mean, it was a farming community, and they had this grain silo that when they would harvest things, they would put all this corn into the silo, and this woman was telling me they would have just tons of debris of fine debris from the corn that had been husked away, and the corn was mainly feeding cows and things like that. But they would just have it cover the cars and everywhere in the city. And so I said, well, this is kind of really interesting that you have all these people in a really small town who have this disease that isn't that common. And so that led to our going up and looking at this small community and seeing if there was some link between what was happening. And that's when we discovered these silos and the stuff that covered it. Now, we never went up at the time I don't think we ever visited the town, but we went up to the town and we mapped out where all these people were living, how they were interrelated or connected, and then found that we think that it had something to do with the corn that they were putting in these large silos and all this debris that would be all over the town. And that got published in the American Journal of Epidemiology. Well, we also went up and we drew blood from them. And so that's where this guy Plouffe came in. FACD was the chair of infectious disease at the time when I was there in Ann Arbor. And we would, why you're not going to like this, Kim, is because we would drive up north of Ann Arbor, and we would have to go through Saginaw and then take a left and go over toward Grand Rapids and to get to this town. On the way to Saginaw, though, there was a town called Frankfurt or something like that, which had two competing chicken restaurants and fried chicken, best fried chicken that I think one of the best fried chicken places, and they'd bring it out, and serve it family style with all sorts of fixings and stuff like that. terrible for the diet, but I know that's what you'll say, but we would always stop there. And they're also noted in that town for having Christmas decorations year round. But we would always stop and have lunch or dinner at one of those two places as we went up there. But we collected blood and we found out that probably in the corn dust, there was phytohemagglutinin, which is a stimulant that's used in the laboratory to stimulate lymphocytes. And we sort of postulated, and eventually was published in the Clinical Experimental Immunology. We postulated that was in some way related to why these people were getting Hodgkin's disease, that it was stimulating their lymphocytes in some way. Anyway, okay, so then I went into dermatology. And I decided I'm curious, and so, I mean, you're going to hear throughout this, I'm curious about what happens to people. And I read an article before I was entering dermatology about, it was in the Annals of Internal Medicine. It was by a woman named Barnes, and it was about dermatomyositis and malignancy. And I had become interested in the derm room interface. And so I decided I would participate with a couple of the rheumatologists, Boll and Kay, and Hyla, who was a rheumatology fellow. He was a contemporary of mine in internal medicine. And we decided we would examine the relationship between dermatomyositis and polymyositis in relation to how frequent malignancies were. And we basically found that dermatomyositis was associated with malignancy, but polymyositis probably wasn't. And that started my career in talking about that disease, which I still do, and I still participate in studies, as you'll see later, that relate to dermatomyositis. And at the same time, there was a pathologist who was very interested and I was interested in internal malignancy, but he was interested in squamous cell carcinomas. And there's a squamous cell, it's called Bowen's type of squamous cell carcinoma, and there's a non-Bowen's type. And we examined patients who had that and did sort of an epidemiologic look back, a retrospective study after we characterized their disease. And then that both those ended up getting published in Archives of Dermatology, which is now called JAMA Dermatology. So anyway, as I said earlier, I'm a skin internist. I focus on internal disease and the use of systemic drugs and complex, medical dermatology. Okay, so in '77, as Kim said earlier, I arrived in Louisville. I joined a practice that was a private practice that was affiliated with the university and was running the residency program. And I decided I was going to still focus on these areas of interest that I had. Ruth Hanno was one of our first-year residents on the day that I arrived. She and I arrived at the same time. So I was a junior faculty. She thought I knew everything because I was a faculty member. Whenever the resident comes in, there's somebody who is above them. They think, whatever. Anyway, Needleman was a fellow in pulmonary. Eiferman had just arrived. Some of you may know him. He's still on staff in ophthalmology. And so we started looking at patients who had biopsies that showed cutaneous sarcoidal granulomas and whether or not they had evidence of systemic disease. We also, Ruth and I saw some patients who had this sort of strange eruption, which was urticarial and was occurring at the end of pregnancy. And that was early on. This eruption had been called pruritic urticarial papules and plaques of pregnancy. Now it's called, now it has a different name. It's called polymorphic eruption of pregnancy. It occurs in first pregnancies. Usually the people are heavier, and we described a group of patients with that disease. And then I had access to a dermatopathology laboratory, which was coding things pretty well. This is days, we're talking about '77, we're talking about days before really good coding and really good computer systems were around. Mm-hmm. But I was able to get data and collect data on patients who did a retrospective chart review essentially on patients with lupus, patients with vasculitis. We went on to publish these things, and then I've collaborated with people over the years. So Ruth Hanna went on, at this time she ended up at Henry Ford. And then the people that I had worked with at Michigan, that's Voorhees and Wu. And then Bickers, I had noticed that patients who were given hydroxychloroquine, Plaquenil, this is a trade name, for their dermatomyositis, seemed to have eruptions that improved. And so we published that with the help of others who were seeing the same thing in their patients. And then we began to collect some serum. And I participated with this guy, Kulik. Fowler's is a practitioner in town here. He's known for contact dermatitis. I tried to get him involved in systemic disease, but he said we need people who do some contact dermatitis, and he's nationally and internationally known. Actually, before that, he was one of our derm trainees. But while he was a trainee, he participated in these studies that list his name there. And then you see John Klein, who has now become very involved at a high level at our university. He was involved in some of the serologic analysis of many of these patients here in Louisville. And then Ira Targoff, who's at Oklahoma Research Institute. Tom Woodcock's a retired oncologist who was chief of oncology here in the days that this was taking place. And then I've collaborated with some people from dermatopathology who aren't in Louisville. At the time that the first one up there was done, it was collaboration with people at Johns Hopkins. I'd become friendly with Tony Hood, who was eventually the executive director of the American Board of Dermatology for a number of years, but she's a dermatopathologist. And then one of the funded research projects that we did was the second one down in Green. I don't know why the kidneys are there, because I don't know that it has anything really to do with kidney disease, but it's you put this thing up and it can design things for you. Sometimes they're meaningful, sometimes they're not. But we had noticed that there were people who had, at the time that we did this study, our colleagues in rheumatology were often asking us to do something called a lupus band test, which is where you would do a biopsy on somebody's skin, send it for immunofluorescence, and if it was positive, it was more likely that the patient had systemic lupus. And it should have been done from the buttocks, from non-exposed skin. And so what we had noticed, though, was the way that we were doing the test was we were put into a medium called Michel's medium, and then send it off for the immunofluorescence lab to analyze it. And Vilma Fabre at the time was a resident. Mo Reichland was a rheumatologist who was at that time, I think, at Buffalo. And Steve Hodge was a dermatopathologist here. He was running the immunofluorescent lab here. And we applied for a grant from the Dermatology Foundation and actually got it. So I do have participated in research where I got the funds. That's a small amount, but we did get funded for that. And we looked at whether patients who, when the tissue was put into Michel's media, and we found basically there were 20% of patients who had a false positive. These are normal, healthy people. And then the next one down, the one in blue, was a study where we were participating in. We had a couple of patients who had this rare condition, lichen planopilaris. It's really rare. It's a cross between pemphigoid, which is a relatively common blistering disease in older people, and lichen planus, which is a common disease in younger people. But the combination is really a rare finding. And so Louis Diaz, who I had come across when I was in training, he was at that time the chair of dermatology at Milwaukee, and had a research lab, and we sent sera on our patient and participated in the study that's listed there that got published in Investigative Dermatology. Now then I collaborated with a friend at Wake Forest, Joe Urizzo, and our contact here was a resident here at the time was Mark Jackson. And then Urizzo at the time was chair at Wake Forest. Alan Fleischer was at Wake Forest. He's now the program director. He was chair at UK actually for a while, and then he's chair. He's up in Cincinnati as the program director there now. But we put together a group of about 43 patients with pyoderma gangrenosum, a relatively rare condition here in Louisville, with 43 of their patients, and then described it. It got published in Medicine. And then we've collaborated again with people who were outside of Louisville. That's Tony Hood again, who at that time was at Indiana University, and Janine Malone, she's one of our faculty members. We did a study of patients who had a thing called SWEET syndrome, which has nothing to, should be capitalized actually, because SWEET is a proper name. It doesn't have anything to do with sweets. It doesn't have anything to do with sugar, fructose or glucose or anything like that. It's an inflammatory process, which is neutrophils that infiltrate the skin. It relates to pyoderma gangrenosum as well. And patients have frequently have internal malignancy, particularly leukemias. Anyway, we did that, and that got eventually published. We looked at, let's see, with a woman named Vicki Worth, who's at the University of Pennsylvania, who also does rheumatology, dermatology overlap with me. We collaborated in looking at our patients' serum, and that was published at some point in time. And then I began to get involved in things that are Delphi type studies. So Delphi studies they're interesting when you participate in them. Everybody gets, you get this computerized data, and you say, do you think this is a really important feature of this disease, or this isn't an important feature to make a diagnosis? And I participate in a number of those and still continue to do that. And then, as you see on the last one down there, Courtney Schott was who is a member of our faculty and is our program director, was a resident at Vanderbilt at the time, but she had a pretty good inkling that she was going to come here. And I wanted to collect some data about involved people at Stanford, David Fiorentino, and as a dermatologist at Stanford, and Lorinda Chung is a rheumatologist at Stanford. And we collected our data on patients, how malignancy was searched for. And so you see that there's a theme here of dermatomyositis coming through, if you haven't seen that already. And then similarly, we did a Delphi with people from Penn, and Mavrorakis actually is at UC Davis in California. He was the lead on that, but I was participant in diagnostic criteria for pyoderma gangrenosum. And then with the Sunda Quarter, that was the most unusual sort of collaboration, but was part of that as well, in getting together some revised criteria for cutaneous vasculitis nomenclature. And then we, let's see, we did something again with a bunch of people that are looking at this, let's see, Olaroyd, and I'm still working with, is a rheumatologist in England. And he's worked with Chinoy, who's also in England, but also with people in the States on trying to get together guidelines for screening patients who have inflammatory myopathies. Okay, so some of the things that I consider pivotal sort of observations as I've gone along. I think I was the first person to actually describe scalp involvement in dermatomyositis, and that was important enough that it was published in JAMA. Then the third one down was something. This was an interesting one. The third one down, because we had a bunch of patients who had peristomal pyoderma gangrenosum. Most of them had inflammatory bowel disease, not all. And we described the features of 5 patients in this article. We actually had, I think, 8, but through the process of the editorial process, the JAMA people made us remove. One of our big points was you have to do biopsies in pyoderma gangrenosum, not to make the diagnosis, but to exclude the possibility of other diagnoses. And we had 3 patients who we knew had pyoderma gangrenosum, but we hadn't done biopsies on. So they said, yeah, throw that out. So we did. With about 3-4 months later, there was an article in Archives of Surgery, which is now JAMA Surgery, where they had 20 patients, and only half of them had biopsies of peristomal pyoderma gangrenosum. Now, so the thing is that the specialty journals are a little less stringent than the JAMA. The JAMA editorial process was interesting to go through with those 2 instances. And then we were, I think, among the first to describe subacute cutaneous lupus occurring from this particular drug. It had been known to occur with drugs, and one of the studies I did that John Klein was involved with was on drug-induced lupus, but we noticed it for terbinafine. Again, the theme of the first one up there it's not so colorful on this slide, but the first one up there was Michelle Pelly was a resident at another program, and she got a grant to come and spend a month here. And before she got here, I actually had this approved by our IRB, and we gave her the task of collecting data on our patients with dermatomyositis and comparing it to patients who had cutaneous lupus, because we noted that patients who had dermatomyositis had a risk of drug reactions when we gave them hydroxychloroquine, which earlier I told you works for their skin disease. But the problem is about 1/5 of the patients will have a drug reaction. And so we always warn patients about it. We were also among the first to note that mycophenolate mofetil might be useful for patients who had skin disease and dermatomyositis, also pyoderma gangrenosum. And then the last one down is an interesting, again, another story. John McGrath, we've had him here in Louisville a couple of times. The first time he came to Louisville, he came to, he's a dermatologist who is a geneticist. He's the head of dermatology at St. John's in London, and he's now become the editor of the British Journal of Dermatology. We brought him here to speak at an annual meeting that we have in the spring called the UofL Spring Meeting. It was started before I came to Louisville, but we've kept it going. And we actually had him here again this past May for the spring meeting again, because Dr. Culpshorten, who just retired, that was her choice. We were honoring her on her retirement. She was, we invited him to come back. But what happened at the meeting was patients are presented. And in those days, and this year we did it for the first time again since COVID. But when COVID hit, we kind of went away from live patient presentations. But traditionally, our spring meeting, we would have a group of patients, we'd room them, and we would see them. People would go and look at them. We'd have a write-up on them, and we'd look at them for about an hour. And then we go down and we discuss them. And Al Knabel, who's one of our clinical faculty members, practices in Southern Indiana, had seen a number of patients, and Carol Culpshorten had seen a number of patients here in Louisville that all had this sort of strange cutaneous eruption that was seemingly sun-related and worsened by sunlight. It was kind of what we call poikiloderma. Poikilo means changeful, and derma means skin. It's hypo and hyperpigmented and erythematous rash on the skin, and they were all interrelated. Again, sort of going back to it, we noticed something. I told you in the beginning. We noticed that patients had a cluster of Hodgkin's disease. Well, we had a cluster of patients who were related. They were cousins and uncles and aunts and stuff like that, and they all had this strange skin. But in addition, they had a high rate of having oral squamous cell carcinoma in the upper respiratory tract, so up in the tonsils, in the mouth. And that's why, let's see, where is he on here? It's one of our, I'm sure he was listed on here, one of our oral surgeons at oral pathologists at UofL was part of this study as well. Anyway, we presented several of them, and McGrath was fascinated by it. And I hadn't seen these patients until the time of the meeting. And I said to John, he stayed after the meeting, and he was our guest. We took him down to Bernheim. We were going around, and he considers himself a gene hunter. That's what he calls himself. And we were out walking in the forest. We were not hunting for anything. But I said, we have this group of patients. Isn't there a way there must be some gene that is causing that? It looks different from other conditions that had been described. And so what we did was got together the patients and drew blood on them, sent it to England, where he had this guy Tanaka, who he was working with, analyze it, and we mapped the gene and found the gene for this particular syndrome. And it's a family cluster, and they're all interrelated. They've seemingly intermarried and stuff like that. It's not Eastern Kentucky, it's Southern Indiana. But okay, so what's going on currently? Well, I've still been involved with this international group that is studying idiopathic inflammatory myopathy. That's what IIM is. And we're still trying to figure out what the best way is to screen patients. we have come out with a publication more recently, just this past year, maybe a year and a half ago, where we made recommendations, but we're trying to hone it down by looking at the actual patient data and seeing how it applies. Dr. Zano, who, when she was a medical student, actually, and Dr. Jones, who was a resident, noted a group of patients who had epidermolytic hyperkeratosis who responded to a drug called ustekinumab. It's a drug approved for psoriasis. That shouldn't have anything to do with this genetic disease. And the same thing happened. Basically, we presented these patients at a meeting. In this case, we presented them, I think, virtually, because Keith Choate was our guest speaker. He's now, at the time, he was a faculty member at Yale. He's now the chair of dermatology at Yale and does dermatogenetics as well. And so we, Mallory and Jordan Jones, got together these patients, drew blood on them, and we've mapped it to a certain gene, and that's why, and we can predict from that, knowing that gene mutation, that they will respond to ustekinumab. And so if we locate somebody who has something similar, even though it's an inherited disease process, they'll respond to this particular drug. And then a couple of studies that are being done by our current senior residents, Yasmin Humeda. She wants to be a Mohs surgeon, and so she is working with Mike McCall and Tim Brown, who are, as I said in the beginning, some of our volunteer faculty members in derm surgery. They're looking in conjunction with people at Northwestern. They're looking at some rare non-melanoma type skin cancers and doing putting together some data on that. And then Eliana Zamora with Courtney and then someone from, I think she's from Mississippi, another resident, are putting together a skin cancer awareness and preventive behavior and health education preferences in the Latino community. That's Eliana is Cuban background. Mm-hmm. That's why she's focusing on the Cuban background. But that's what's going on at the current time. So, yeah, I haven't taken all the time, but I'm going to be short time, so we can now get our salad together if we want. Those of you who are here that might want salad. Anyway, so sort of concluding, what I think I've told you as I've weaved through my part of my CV that can be read or whatever. There are a lot of different ways of doing research. Gathering new material, gathering new information that include clinician educators. They can participate in collection, presentation, and publication of original observations. You just have to be curious. You have to be at the bedside and say, oh, there's something different about this patient. I mean, every patient's different, but there's something uniquely different about this patient. Let's think about that. Why is it happening? And it's possible to do such as long as you're willing to devote the time. and anybody who, see, when people say to me, well, I say it too, I don't have time to do that. That isn't really right. It's not the right statement to me. It is, I haven't prioritized the time to do this. I don't want to do it. It's okay to say, I don't want to do it. I don't want to prioritize that in my life. I don't have time because I don't want to do it. But it isn't that you don't have time. You have time if you want to take the time to do it. Funding is a possibility. Obviously, I've probably, let's see, while I haven't, except for one instance where we applied for a grant, I personally didn't have the funds to do these things, but I found people who did. Sometimes we would provide a little bit of, if we had a little bit of clinical money that we could use, we would provide a little bit if we needed to buy some tests or things like that. We have one case, Dawn Castor in in the nephrology, got interested. We had a visitor here, I think it was a virtual visiting grand rounds on sarcoidosis a few years ago. And she got interested because I had a patient, they were talking about sarcoidosis and granulomas. I had a patient who had a granuloma annulare, which is that's another one we're working on currently anyway. Dawn got all excited about it because I had this patient who had this widespread granuloma annulare. We treated him with hydroxychloroquine. He got all better. And I was following him along, and eventually he developed some kind of ocular disease, which people thought was sarcoid, but it isn't. And then he developed nephritis, and then subsequently developed myelofibrosis. And it probably he has in his sarcoidal granulomas, he has an abnormality that would predict that it's the same as the abnormality that he developed in the myelofibrosis, and we're still working on that. So anyway, funding is a possibility, but it's not a necessity for doing things like this. Anyway, that's my spiel. It's totally different than probably anybody expected for this, but hopefully you enjoyed it.
Well, thank you very much. We'll open it up for questions, but I've got two of them taking advantage of the idea that you're a skin internist. There are two very fascinating things, one in cardiology, one on oncology, that I've seen a few times after reading about it. It's always helps to read and help you with your patients, which is basically what you've been doing. One of them is the so-called Frank sign. That is diagonal earlobe creases, preferably bilateral.
Yeah, there was something written about that recently.
But what in the world does that have to do with obstructive coronary artery disease?
I think people have kind of debunked it mainly. I don't know that it really does.
Well, okay, so it's come and gone. People debunking it, and then it resurfaces as no, there really is. I can tell you that from my clinical practice, looking for earlobe creases, it's got a lot of depth to it. Obviously, there's some false positives, but the false positives are way less, it seems, than the true positives. But that may be the fact that there's just enough people doing plant-based nutrition and everybody's got coronary disease. But it's supposedly specific for obstructive coronary disease. But you're thinking that there is no mechanism, there really is no
I don't know that anybody has done biopsies to find out if there's anything there that would clue us to that. I mean, these people have this. It's not something that happens as an acquired thing. So is it some So I mean, simplifying things, I think that everything is either. Let's say I think everything is related to our genetic makeup. We have a propensity to get a disease, and then our environment has some, but it weighs on the things that we're genetically predisposed to get. I mean, and can you modify it? Yes, I know you're going to tell me that we can modify it with a vegan diet, so I think either things are related to your genetic makeup, to drugs that we take, or to infections that we get, and we handle them differently. I mean, there's so many questions. I mean, I have so many more questions than I have answers.
Right. So, well, the oncology one that's always been fascinating is the sign of Lesser-Trellat.
Oh, yeah.
And what in the world does that have to
Yeah.
do? If no one has seen that, please, if you're not
Yeah.
sure what I'm talking about,
So the, yeah,
Google it so
on
you
the,
can actually see.
yeah,
what it
actually,
looks like.
we have, what do we have?
Same
We have a
people?
good number of dermatologists on here.
Oh,
you know.
okay. So, and they're all
Um,
familiar with it.
Well, I don't know if they're, yeah, they should be, and we had a couple of students on here.
Mhm.
Yeah, we were heavily into that, but, yeah,
Is there a
they're signing
mechanism?
off. Is there a mechanism? So for those of you who don't know what the sign, who in the room knows what the sign of Lesser-Trellat is? Aside from Kim and myself, do you know?
I think so.
Do you think so? Okay. I won't ask.
So if you Google it, it's just very striking.
Yeah, so the sign of Lesser-Trellat, I've written about it in papers, and I
Have you
think
not?
I've seen it once. And I remember I've been practicing, let's say I started in dermatology in 75, so 50 years worth. And I've seen it once. It is one of two things. It is the rapid appearance of seborrheic keratoses, or the rapid change in existing seborrheic keratoses. And it's associated with, in a majority of people, it's associated with, is that from the New England Journal? They had a recent, I think they had a recent one that they published.
Oh, it's in a higher level journal. It's called Med Dizzy.
Yeah. But it's supposed to be associated with internal malignancy.
Yeah.
But it has been associated with acanthosis nigricans. I have seen that and internal malignancy, and nobody knows exactly the mechanism of that. But they think it's due to epidermal growth factor, the acanthosis nigricans, which is velvety changes on the neck and under the arms.
Right.
Now, acanthosis nigricans is relatively common because it's seen in diabetics, particularly who are obese and
Kind of a
overweight.
syndrome.
And particularly, yes, if you see this sort of, looks like dirt on the back of the neck, it doesn't wipe off. It's not terra firma, which you can wipe off. You know, people that are dirty, you can wipe it off, but this you can't wipe off. And if they lose weight, and if they get their diabetes under control, that goes away. But in people who have acanthosis nigricans, where it's associated with weight loss and glossitis and angular cheilitis, that's highly related to internal malignancy, particularly in the gut, the GI, the stomach more so, adenocarcinomas of the stomach. And if you effectively treat that, the acanthosis nigricans goes away. So Lesser-Trellat is sort of a sign that's kind of like that. Nobody has really, there haven't been enough patients for anybody to do any meaningful studies to look and see if there's epidermal growth factor that's in the circulation that might cause that.
Well, thank you so much. I'm looking at the chat. It doesn't look like we have any questions, but any from the audience here? The audience has doubled in size. Okay.
I was gonna say, I appreciate your history. I didn't know, fascinating individual cases, and you've been prolific, so that's pretty cool. I didn't know you did all that.
Fantastic. So thank you so much. I guess we were not going to hold up lunch any longer. So
It's here.
all right,
Oh,
fantastic.
lunch is here.
It faded, yeah.
Oh.